This talk is on multiple sclerosis and acute disseminated encephalomyelitis. I want to give a special thanks to Robin Balabanov, who contributed slides to this deck. He is a multiple sclerosis doctor who used to practice here at Rush. These are the lecture objectives for this talk. The first is to understand the role of the immune system in multiple sclerosis, to be able to identify the pathophysiology of conduction in demyelinated axons, to explain recovery of function in multiple sclerosis, to identify the MRI appearance of multiple sclerosis, to be able to describe the therapy for multiple sclerosis, and to define acute disseminated encephalomyelitis and how it differs clinically from multiple sclerosis. Multiple sclerosis and ADEM are diseases of the white matter and myelin. As a reminder, gray matter contains neuronal cell bodies, and white matter contains myelinated axons. Myelin is a proteolipid insulation of the axons, and oligodendrocytes are the myelin-producing cells. There are many diseases of myelin. Demyelinating diseases tend to affect the preformed myelin and can be caused by a number of etiologies, such as vascular etiologies, toxic exposures, inflammatory reactions, or viruses. Leukodystrophies, which will be in a second talk, affect myelin formation and maintenance, and tend to be caused by genetic or hereditary factors. Multiple sclerosis is a disease of the central nervous system myelin. Multiple sclerosis is the primary demyelinating disorder of the central nervous system. The demyelination is caused by an inflammatory reaction directed against the myelin, and multiple sclerosis lesions will display a specific pattern of chronicity and recurrence. These are lesions that are separated both in space and time. We will come back to this in a later slide. The etiology of multiple sclerosis is unknown. However, there is about a 5% risk that it will be passed down in families. On the left-hand side, you can see a list of demyelinating disorders. And I'd like to focus for you some of the disorders we are going to cover in this slide deck, multiple sclerosis and acute disseminated encephalomyelitis, but also some other disorders that will be in a second slide deck, central pontine myelinitis, and some leukodystrophies. All of these disorders will be covered on step 1. The classic definition of multiple sclerosis is that it is a chronic autoimmune inflammatory demyelinating disease of the central nervous system. The peripheral nervous system is rarely affected in this disease. There are 4 forms of multiple sclerosis: relapsing remitting MS, secondary progressive MS, primary progressive MS, and relapsing progressive MS. Relapsing remitting MS is the most common form of multiple sclerosis, and especially the most common that you will encounter on the wards in the hospital. MS is a clinical pathological syndrome. Again, the etiology is unknown. This picture depicts the clinical forms of multiple sclerosis. In the top of this graph, in the yellow, you can see the relapsing remitting course of disease. The patient will have preclinical disease at the beginning, meaning they've not yet been diagnosed with multiple sclerosis, and then will develop an acute new neurological deficit, or what we call a clinically isolated syndrome. They will recover some function, or maybe all function, and then later on will have a relapse or have another acute onset of a different neurological symptom. This makes up the typical course for relapsing remitting disease. In the second, or blue lines, you can see the course for secondary progressive. These individuals also start off with what would be called a clinically isolated syndrome, but never quite fully recover back to baseline, and instead have a progressive course after that first acute onset of a neurological deficit. Primary progressive patients will just accumulate neurological deficits over time and never have clear recovery in between. And finally, you can have kind of a combination of the above called progressive relapsing disease, where you do have continued progression that is interspersed with new acute onset of neurological deficits. Many of these forms of disease will reach a, quote, burned out state, where you do not necessarily have acute onset of new neurological deficits. You just have a lack of return to baseline. The natural course of multiple sclerosis has several specific clinical events, such as the clinically isolated syndrome, when you have one acute neurological deficit, versus relapses, remissions, or progressions. And all of these can occur in both the recurrent and chronic patterns of multiple sclerosis. The multiple sclerosis relapse is important to understand as this is frequently tested, and it is defined as the appearance of new symptoms or worsening of pre-existing symptoms that last for more than 2 days and can last for up to 2 to 3 months. This is what's called an MS relapse. A relapse can be associated with virtually any neurological symptom or sign that is found in the central nervous system. Multiple sclerosis progression without a relapse is characterized by the slow accumulation of deficits, mainly gait abnormalities, spastic paresis, and ataxia. And this appears to be a common end pathway of the disease. Patients will be defined as having clinically one of these forms of multiple sclerosis, although other investigators will call some patients benign, as having benign multiple sclerosis, or burned out multiple sclerosis at the end of disease. There's evidence for autoimmunity in multiple sclerosis, and this evidence includes the following. There is the presence of inflammatory infiltrates and immune-mediated injury in the central nervous system. And these patients look a lot like those patients who have chronic transplant rejection. In patients with multiple sclerosis, you can isolate self-reactive T cell clones and self-reactive anti-myelin antibodies. There is a clear existence of immune dysregulation, and the disease is transferable to experimental animals. In fact, you can induce an animal disease that's very similar to multiple sclerosis by injecting myelin antigens. And finally, it is very clear that there is a beneficial effect of immunotherapy and chemotherapy for patients with multiple sclerosis. Now, I will tell you that the evidence for autoimmunity for multiple sclerosis has developed quite recently. And when I trained in neurology and did my neurology residency, we did not understand that it had a clear autoimmune basis, nor did we have many of the medications that are now in existence to treat the disease. There are many risk factors for multiple sclerosis. These include environmental factors, hereditary factors, and immune dysregulation. So environmental factors include the occurrence of MS epidemics and clusters in geographic regions. There also appears to be an effect of migration. If you move from a geographic region with a low incidence of MS to a geographic region with a higher incidence of MS, you will take on the risk of the higher incidence of MS area. There is also an implication for bacteria and viruses, and the best evidence is for Epstein-Barr virus being associated with multiple sclerosis. There are several non-microbial factors such as vitamin deficiency or the sunshine theory, and this translates into the fact that multiple sclerosis is more common in areas at latitudes that are farther away from the equator. The closer you live to the equator, the less likely it is you will develop multiple sclerosis. So of course this is not helpful for us here in Chicago. Smoking also appears to be a risk factor for multiple sclerosis. There are several hereditary factors that can predispose you to have a higher risk of multiple sclerosis. There appears to be an increased risk if you have an affective immediate relative. There is a linkage to the HLA genes, the MHC class II. And there are several hereditary factors that determine immune response that are also associated with the disease. In patients who have multiple sclerosis, there does appear to be immune dysregulation with molecular mimicry and epitope spreading, causing a disbalance and dysfunction of T cell subsets. There is also activation and expansion of cell-reactive T and B cell clones. What occurs in multiple sclerosis is an inflammatory demyelination, and this picture shows the path with which this happens. So at number 1, you can see there's a generation of autoimmune response in the periphery. And then subsequently, you will have leukocyte transmigration into the central nervous system. There is then an interaction between the immune system and the central nervous system cells, and that will result in demyelinating and tissue injury. The loss of myelin results in an axonal conduction block. So what you can see on the left is a healthy nerve, which is normally conducting information down the nerve cell. But on the right, you have disrupted the myelin due to the demyelination in multiple sclerosis. And because of that, the information is not getting all the way down the nerve and is being stopped part way. The symptoms due to demyelination are recoverable. However, patients who will come in with multiple sclerosis typically will present with action-induced fatigue and something called Uthoff's phenomenon. Uthoff's phenomenon is when the symptoms of multiple sclerosis will worsen in the setting of increased temperature or heat, such as taking a warm bath. There are some medications that appear to improve the conduction velocity in multiple sclerosis. One of these is a potassium channel blocker, which was actually developed here at Rush University. The persistent loss of myelin results in axonal degeneration. And what you can see on the left is a picture showing the loss of myelin and then subsequently the generation of the axon that is lacking the myelin. Now, when the demyelination occurs, the hope is that the central nervous system will remyelinate in these areas so that you don't have a permanent lesion. Now, there are these plaques that occur in the brain in multiple sclerosis. And on the left, you can see the white plaques are demyelinating plaques, and this is what they look like in pathological specimens. On the right, you see plaques that are a little bit darker, and these were called shadow plaques, or are called shadow plaques. It was originally believed that shadow plaques represented areas of only partial demyelination, and that's why they did not look as severe as the demyelinating plaques. But we now know that these shadow plaques represent areas of remyelination, and this is quite exciting in the field of MS when this was discovered. However, remyelination in multiple sclerosis is inefficient and only partial. The new myelin appears to be thinner and has shorter internodal distances compared to normal myelin. When we think about multiple sclerosis, we recognize there's a bimodal distribution of relapsing remitting MS pathology. On the left, you have patients who have relapsing remitting disease, and these patients have inflammation and relapses. They would tend to have gadolinium enhancing lesions, so this is the contrast we give in MRI scans. When you give the contrast prior to the MRI scan being performed, what we can see is that an acute inflammatory lesion in MS is going to light up with the addition of the contrast. And this tells us clinically that the lesion is active and inflammatory. However, as the disease progresses, and if the patient turns out to have a progressive course or progressive MS, what we actually will see is neurodegeneration. You will develop overall global volume loss, or what we call atrophy, and you no longer will see gadolinium or contrast enhancement of those lesions on the imaging study. And you can see the difference in the scans on the left side of the slide and the right side of the slide. With the left side of the slide, you can see these bright contrast enhancing lesions that appear to be almost white. Let me circle some of those for you here and here. Whereas on the right side of the slide, we don't see those contrast enhancing lesions. Let's talk a little bit about the pathology of multiple sclerosis. In the blue box, we have the white matter or classic lesions. These are focal areas of demyelination that are typically located in the periventricular white matter. The demyelination is mediated by T cells, antibodies, and reactive oxygen species. Almost all cellular elements in this periventricular area are affected or involved, and these include the oligodendrocytes, the axons, the astrocytes, the microglia, and the blood vessels. Cortical lesions can also happen in multiple sclerosis, and these are focal areas of demyelination of the transverse cortical fibers. This demyelination is mediated by microglia, reactive oxygen species, and CSF toxins. We can see lymphoid folliculi in the meninges with formation of B-cell germinal centers in the Burkow-Robbins spaces. And then we also can see what appears to be normal appearing white matter. However, if you look deeper under the microscope, you will see activated microglia, apoptotic oligodendrocytes, upregulation of cytokine expression, and axonal degeneration. This is another picture of the pathological findings of multiple sclerosis. And what you can see if you look deep at a cellular level, this inflammation of the T and B cells in the upper right-hand corner, myelin loss and axonal transection, activated microglia, and astrocytosis. The classic semiosis in multiple sclerosis are the following. Multiple sclerosis is a multifocal disease. Multiple sclerosis lesions can occur anywhere in the central nervous system and can produce a wealth of differing neurological symptoms. Multiple sclerosis is a white matter disease. While any known neurological symptom can be associated with multiple sclerosis symptoms such as aphasia or seizures, these cortical symptoms are rare in multiple sclerosis, and we can sometimes classify these as white matter versus gray matter symptoms. There's this concept of the strategic lesion. Although some of the MS lesions are clinically silent, others are highly detrimental. For example, if you have a multiple sclerosis lesion that is located deep within the frontal lobe, you may not have any neurological symptoms that the patient is complaining of, nor any abnormalities on the neurological exam. However, if you have a multiple sclerosis lesion within the spinal cord, it is very likely that your patient is going to be having symptoms related to having problems in the long tracts. Multiple sclerosis symptoms usually have a subacute onset. Because of their inflammatory nature, they tend to progress over a period of a couple weeks and then can last 1 to 2 months if they are not treated. Multiple sclerosis symptoms are chronic and recurrent, and that reflects the nature of the disease that we talked about a few slides ago. Multiple sclerosis symptoms can fluctuate throughout the course of the day or worsen with exercise, heat, infection, or the menstrual cycle. Finally, early in the disease, multiple sclerosis symptoms will resolve, implying that there is tissue repair or compensation. But later in the disease, the symptoms tend not to resolve but continue to progress, implying irreversible damage within the nervous system. Let's talk a little bit about the clinical presentation of multiple sclerosis. This disease is more common in women in their 20s to 30s. However, we see it in both men and women and at later and earlier ages. This disease is also more common in Caucasians who live far from the equator. And again, this is related to the risk factors we described before about vitamin D. Multiple sclerosis patients tend to have a waxing and waning course, and you'll want to ask them whether their symptoms are exacerbated with heat exposure. These patients tend to have motor and sensory deficits, and they tend to have characteristic eye findings, which we'll go to in detail in a couple slides. These findings include optic neuritis and intranuclear ophthalmoplegia. Lhermitte's sign is a sign typically described in patients with multiple sclerosis, and it occurs when patients have a lesion in the spinal cord. The sign is that when the patient will flex their neck, they will notice electric shocks that go down their back. And again, this localizes to a lesion in the cervical cord. These patients will also have problems with bowel and bladder dysfunction. Charcot, a neurologist long ago, described several clinical presentations of multiple sclerosis. The first is the myelopathic presentation. These patients will present with spastic quadriparesis and paraparesis. It can be difficult to diagnose if you don't see any brain lesions, and it is very disabling. Patients can present with cerebellar or brainstem presentations, and these patients will have ataxia. This is also disabling because of the risk of falls. Finally, you can have a cerebral presentation, mainly cognitive and psychiatric in symptoms. Although this early in the disease course it can be mistaken as benign MS and not be treated, it is much harder to manage later on. A mixed presentation of these is most common, but again remember that lesions in multiple sclerosis can affect any part of the central nervous system, so almost any neurological symptom can be part of the presentation. I'd like to focus a bit on the eye abnormalities in multiple sclerosis. The first is optic neuritis, and optic neuritis occurs when you have demyelination of the optic nerve. Patients will present with a decreased vision, typically in one eye, although it can occur in both eyes at the same time. Up on the left-hand side of the slide, you can see a normal disc, and what you can see is the sharp disc margins around the optic nerve. Below, you can see that the disc margins are blurred. These disc margins that are blurred we've seen once before when we discussed papilledema or increased intracranial pressure. However, in this setting, we also see blurred disc margins in optic neuritis. Again, your patient will frequently present with vision loss on one or both eyes, and on examination they will have blurred disc margins. Other eye abnormalities can occur in multiple sclerosis. We discussed the vision loss associated with optic neuritis, but a relative afferent pupillary defect can also occur, and this is called the Merkus gun pupil. I have a video here for you to watch to explain it further. What this is that when you shine your flashlight directly into each eye, both pupils will react normally. However, if you have demyelination in one of the eyes, what you will find is that when you give quickly that light into each eye, the light, both pupils will dilate instead of constricting because you have a weaker pupillary constriction in the eye that's been affected by the demyelination. And this is called a relative afferent pupillary defect. I would view the video and you can see what this looks like on examination. The second eye abnormality that we will see is the internuclear ophthalmoplegia. These patients will typically present with double vision and is due to a lesion in the medial longitudinal fasciculus. These are interneuronal pathways of cranial nerves 3, 4, and 6. So an internuclear ophthalmoplegia is characterized by an ipsilateral adduction deficit and a contralateral abducting nystagmus. The reason this occurs is because axons for the MLF arise from the interneurons that are intermingled within the abducens nucleus. These axons leave the nucleus and immediately cross the midline and ascend in the MLF. Lesions of the MLF then produce an impaired adduction of the ipsilateral eye with this nystagmus of the contralateral eye when abducting. I like to think of it as that one eye is not moving laterally and the other eye is moving medially and trying to push the other eye, and that's why you get subsequent nystagmus. Both of these eye abnormalities are commonly tested on step 1, so make sure that you can recognize both of them. There are several MRI features of multiple sclerosis. Multiple sclerosis is characterized by the presence of abnormal lesions that we can typically see on T2. Lesions can also be gadolinium enhancing or contrast enhancing in the setting of acute inflammation. We talked about that a few slides ago. We will see holes on the MRI scan which appear to be black, and those are areas of necrosis of brain tissue due to destruction. Brain atrophy or volume loss can occur over time and is associated with disease progression. There are some limitations of the MRI clinical correlation, and that's that MS lesions can be silent. Again, if they're located in places that we wouldn't necessarily see neurological signs, such as the deep frontal lobe. Relapses can occur without contrast enhancement of the lesions, especially later in disease. And the apparent number of lesions on the brain only weakly correlates with disease progression, although brain atrophy does. So let's look at some of these lesions. So over here, we can see this is a special type of MRI that is called a flare sequence. And in this particular type of sequence of MRI, we've subtracted out the cerebrospinal fluid and turned it dark, so we can see those areas within the brain that are bright. And here, all of these bright lesions within the brain are going to be multiple sclerosis lesions or plaques. These are areas of demyelination. If we can see any areas of holes, such as right here, there's a black hole. That's an area that had demyelination and now that tissue is dead or necrotic. Down here, we're looking at a sagittal view, so this is cutting the brain in half down the nose. We can see the corpus callosum here, and we can see all of these MS lesions radiating out from the corpus callosum. This has a characteristic name called Dawson's fingers, and it is one of the few diseases that will cause this appearance on the MRI scan. On this figure 3, we can see contrast enhancement of some of these lesions, telling us that these lesions are acute and inflammatory. One of the characteristic findings on MRI of multiple sclerosis is that you will have lesions separated in space and in time, meaning that your lesions are going to be in different locations and they're going to be occurring at different times. On a single MRI scan, you can show both of these. If you have multiple MS lesions, and if some of your lesions enhance but others don't, this gives you evidence that you have lesions separated in space and time. And this is a frequently tested concept on exams. Before we had MRI imaging to use diagnostically for multiple sclerosis, the diagnosis was made by cerebrospinal fluid studies. We would do a spinal tap of the patient and look for these classic findings. Typically, protein and glucose levels are normal within the cerebrospinal fluid. However, the protein can be mildly increased during an acute exacerbation. Cell counts are typically normal, but again can be mildly increased during an exacerbation. Oligoclonal bands, which are seen in multiple sclerosis, are very specific for the disease. However, they can be less sensitive in patients who present with their first acute neurological deficit. Oligoclonal bands are a sign of chronic central nervous system inflammation, and they tell us that you have intrathecal production of protein that should not be there. In addition, we will see in patients with multiple sclerosis an elevated amount of IgG in the spinal fluid. And when you compare that with the albumin or protein in the blood, we have a IgG albumin index that we can use. When this IgG albumin index is increased, this is specific for multiple sclerosis and can also be used for the diagnosis. It is not common at this point to perform a spinal tap on all patients who present with multiple sclerosis, unless there is a contraindication for MRI imaging. However, it is important to understand the role of the spinal tap, the presence of oligoclonal bands, and an increased IgG index in patients who have multiple sclerosis compared to other diseases. Let's talk briefly about treatment strategies for relapsing remitting multiple sclerosis. As of yet, we do not have proven therapies for progressive MS patients. The acute treatment of disease relapses is with IV steroids. IV steroids are typically given to patients who have gadolinium-enhancing lesions on the MRI scan. For patients who continue to have relapses and inflammatory lesions, it can be considered to use other agents such as Cytoxan. In addition, plasma exchange or IVIG is also used in the acute setting. Chronic treatment, in order to reduce the number of relapses that occur, can now be given for extensive periods of time. And there are both first, second, and third line therapies for patients. First line therapies include medications such as Avonex, Betaseron, Copaxone, Rebif, and Extavia. Second line therapies have a risk of side effects, including Tysabri, and that is why they are reserved for patients who fail the first line therapies. These therapies are going to work within the immune system to lower the inflammatory reaction that is seen in multiple sclerosis patients. And although you don't need to know the details of these medications, you need to understand that they are the mainstay of treatment for patients with a diagnosis of MS. Symptomatic treatment also has a role in these patients. For patients who have neurogenic bladder, which is very common in this disease, these patients will be given specific medications or catheterization on a regular basis in order to pull out the urine. Spasticity can be treated with medications such as baclofen, and pain is treated with medications such as gabapentin or tricyclic antidepressants. We want to remember when we see patients who have T2 MRI lesions that not all of those patients will have multiple sclerosis. We can see patients with multiple T2 MRI lesions who have other diseases, such as small vessel vascular disease, hypertension-related encephalopathy, patients with migraine headaches who are otherwise normal can have T2 MRI lesions, thyroid disease, diabetes, and antiphospholipid antibodies. In patients who have large confluent MRI lesions, we want to be thinking about other diseases as well, such as leukodystrophies or progressive multifocal leukoencephalopathy. I'm going to discuss these two in a later talk. Finally, we can't necessarily rely on the presence of oligoclonal bands in the CSF for a diagnosis of multiple sclerosis, because other diseases will also be associated with oligoclonal bands. Frequently, the non-MS related oligoclonal bands are transient and disappear after the acute phase. However, all inflammatory or infectious diseases can be associated with these bands in the spinal fluid. In the same vein, not all inflammatory diseases of the central nervous system are multiple sclerosis. I'm going to discuss one of these in the next slide. Not all demyelinating diseases of the central nervous system are MS. Again, we'll discuss some of these later. And finally, not all inflammatory demyelinating diseases of the central nervous system are MS. Some of them are not even autoimmune. So we want to remember when we see T2 lesions on the MRI scan that we need to be thinking not only of multiple sclerosis, but of some of these other diseases. So let's discuss one of those now, and that disease is called acute disseminated encephalomyelitis. This is an acute inflammatory demyelinating disease. It will cause numerous foci of demyelination scattered throughout the brain and spinal cord. And it appears to be a perivenular inflammatory reaction of lymphocytes and monocytes. This disease looks very similar to multiple sclerosis, but it is distinguished from MS because of the way the patient presents. This type of disease is very commonly seen in children after they've had an infection, a viral infection. The temporal course is also very different because it comes on acutely and there are not relapses and remissions. It tends to be monophasic. This is what the scan looks like in ADEM. This patient has these demyelinating lesions that are all over the cortex and the white matter. And these lesions all occurred at the same time. This patient below has a similar story. These patients will present with an abrupt onset between hours and days of confusion, somnolence, and seizures. These patients can have ataxia and myoclonus, and many of them will progress to stupor or coma. There is a myelolytic form where these patients will have partial or complete paraplegia, and many of them will have fever. When we do a spinal tap on these patients, their cerebrospinal fluid will have increased protein or cells. And again, on imaging, they have bilateral confluent white matter lesions. The treatment for ADEM is very similar to the acute inflammatory lesions seen in multiple sclerosis by the use of steroids, plasma exchange, or IVIG. That is the end of this talk on multiple sclerosis and acute disseminated encephalomyelitis.